Hello, good evening, everybody. This is Eric Ranchard speaking. I am your moderator for tonight, and we have an excellent speaker today. That's Raym Geis. Raym will talk about implementing ethics into radiology for artificial intelligence or ethics related to artificial intelligence radiology. First of all, I would like to introduce Raym, and he has a quite impressive curriculum. He's a senior scientist at the Data Science Institute of the American College of Radiology. He's also adjunct associate professor of radiology at the National Jewish Health, and he's a clinical assistant professor of radiology at the University of Colorado School of Medicine. Of course, and this is not unimportant, he's also vice chair of the ACR Informatics Commission and a member of the Data Science Institute Advisory Group, etc. So there's a lot of things to mention, and also important to mention is that the fact that he's co-originator of the RSNA SIM National Imaging Informatics Curriculum and courses, and he's a past chair of the SIM, the Society of Imaging Informatics in Medicine, which is our American counterpart and our partner as well. And he's also representing the SIM in our society, the USOMI. So we're very happy to have Raym as speaker, and he also has a very interesting talk. So I will leave the word to Raym now. One thing I have to add is that I would like to invite you to type your questions in the Q&A box. The Q&A box will be also the box where we read the questions for the Q&A session that takes place after the lecture. So the lecture will take about 40 minutes, and then we will have about 20 minutes for the Q&A. So please don't hesitate to type your questions into this box. So please, Raym, you have the word.
Great, thanks, Eric. And thank you all for sharing your evening here, and to USOMI for the invitation. So let's talk about how actually to have ethical radiology AI which works, that does right for patients, and verifiably improves healthcare, both for us as individuals as well as society. Last fall, a lifetime ago, USOMI, ESR, and North American Radiology Societies published this statement on the ethics of AI in radiology. And it's a good document which describes major ethical issues. A lot of other societies have published similar ethics statements, like the IEEE, the EU has one, the Association of Computing Machinery, or ACM, has one. After ACM published their excellent document, though, McNamara looked at the effect of the document, and this is what he found. It had no effect on what we were actually doing. So that's really a bummer. But why is that? A lot of it has to do with this. We build something, it works okay on narrow tasks. We want to get it out quickly to satisfy our investors, to get published and famous, to lay the groundwork for our next grants and funding. But, and we're too busy doing the hard work, to make our product more secure or reliable or efficient or robust. So how are we going to get ethical AI? What do we do to do that, get it on a broad clinical scale? So let's, the first thing we need to do is be realistic. We aren't going to get perfect AI. We need to have frank discussions on how good and ethical is enough, okay? We're not saints, okay? So somewhere between being sainthood and going to prison for what we're doing, maybe we make the front page of the New York Times because we did something that makes people uncomfortable. And so what we're trying to do is find this Goldilocks area, this area which is ethical enough that we're all comfortable for it. And the other thing that we want to do is also define some sort of guardrail beyond which we just say, you can't go there. You're not doing enough privacy, or maybe you're hurting some patients at the cost of others, and you just can't do that. We need those sorts of discussions right away. You know, what are we willing to compromise to make these things incrementally better? We need to write it down. We need to acknowledge up front that we're going to compromise privacy in some ways. Our models are going to be biased. We will help some people more than others. We can't stick our head in the sand or lie and say we're saints and all is going to be well in the world when radiology AI arrives in ways small and large. But on balance, let's be darn sure that we're helping patients and society more than hurting them. Let's do our best to maximize the good parts and prevent the worst. You know, radiology AI is basically idiot savants, and we need to engineer strong, fail-safe systems, controlled input data pipes, and have human oversight of our outputs. Otherwise, we're in trouble. To do this, first, we must acknowledge that this is going to be hard. To build robust products is not our general area of expertise. Most of us are, radiologists, or we're dealing in clinical practice. We need to be humble, acknowledge our weaknesses as well as our strengths, and include experts in other domains. Beyond just our words and ambitions for ethical and robust AI, we need to redouble our efforts to work with technical experts to build and incorporate sophisticated technical solutions. We need solid checklists and measurable metrics and KPIs. Even, if we start with what seem like simple ones, we need to take the first steps. Finally, we want to start now to build the system of independently verifying and validating radiology AI, and which will also help these complex and intelligent and autonomous medical software. So the kinds of experts we need come from all different areas. Certainly we need them, people from society, just to let us know if what we're doing feels right to the general population, because the compromises that we make really are going to be the ones that society is allowing us to make. Not only do we need the medical domain experts, but we need people who are true experts in data science, ethics, biostatistics, all these different things. Not just radiologists or bioengineers that are a little bit better than others in these fields, but true experts. Independent verification and validation. This is a process that was initially started in the 1970s as a way to get a handle on how to build and validate complex systems. It was described initially as software for ballistic missiles. That's certainly a complex system with high consequences. Today, this overall approach has been adopted by many industries, most notably aviation, which is why planes don't fall from the sky on a regular basis. It's also incorporated into what's called the PMBOK, or the Product Manager's Body of Knowledge, which is a big blue book that managers of very large complex systems often use. Verification is the process of both defining upfront that the software is built correctly. Validation is ensuring that the right software product is built and evaluating it at the end of the development process to see whether it truly satisfies the requirements that we've defined beforehand. We want to know technically, does it work? Ethically, is it doing what is right to do for patients and society? And contextually, is it clinical, for us, this means, is it clinically relevant? Is it truly affecting clinical care and making things better, at least incrementally better? So verification is the process of defining upfront at each stage in the product lifecycle what it should do, the goals and metrics to meet to ensure proactively that the product is being built correctly. Okay. We want these checklists that we define before we start the product even, to make sure that we have quantifiable metrics to give us a guideline for what we're actually making. These checklists, we want them to be principles-based. Usually they're going to have layered questions. Some of the things that we want to do is that we want to proactively minimize that technical debt, that, oh, we're building a product right away and we got to get it out of the door. We want to make sure that it truly works. For us, a lot of the things have to do with measuring and minimizing robustness, and also using the product on and measuring the results of how it works with underrepresented groups. And we're going to score these things based on some sort of compliance with these described principles. We can take baby steps. Just, you have your own prototype projects, that we're doing, especially in academics. Make simple lists up front of, what do you want your product to do? Not just like, oh, I want to be able to decide whether somebody has acute hemorrhage or not, but what are the verification checklists that I need about the patient data privacy? What do I need to do about how robust it is against noise or adversarial images? How secure is it? Is it work on underserved groups? And then if I'm going to put it out into clinical practice, I want to proactively develop some sort of system to describe what is the technical monitoring that I'm going to do to verify that it's actually working like I want. I don't want to do these things after I've built the product. I want to do them before. So what are some of the kinds of questions that we want to ask? Well, things like this, what are the benefits of what we're building? What could be the harms? What are we going to do to build this in clinical practice, and how are we going to measure it? We want to think about how we're going to promote data access, but at the trade-off of protecting privacy. We'll think about bias, and we're going to talk about that later, and how to maximize the benefits. We want to really list the benefits that we think we're going to get from our product, and also list the harms. Don't say, oh, well, it's not really going to harm anybody. Yes, any of these things have the potential to harm. We need to make a list of those things if we're going to be able to proactively think about how we might minimize those. So here's an example. If I have, the more I give up my privacy, the more I can use the data and extract information for it, maybe the more accurate I can be. Okay, so if I say that I want a specific level of accuracy, but to get that, I have this certain level of privacy. Now, if I just built it that way, then up front, I've built something that's really compromised the privacy. But if I proactively up front say, gee, the privacy has to also be at this level. Now, if I can't reach that intersection, I shouldn't be building the product. But the next part of this is that there are technical approaches that we can do to improve privacy of the data so that potentially we can reach that accuracy. These are the sorts of things we want to do. And here's an example. I mean, this gets back to the technical parts. We say, okay, if I want to build my algorithm to do a certain thing, maybe I don't need to just, build my deep learning neural net that identifies, say, hemorrhage or not hemorrhage. But I also need to include some of these other things for the data privacy. Maybe I'm replacing some of the specific information with generic or group values. I can use differential privacy where I'm adding statistical noise to some of the characteristics. Maybe I hold some of the data back and only allow it out with a token or encrypted hash. I've got some of these other things, secure multi-party computation, PSIs, PATEs. Those, honestly, I don't know how to do those myself. I mean, I'm aware of them and I can talk to people who are true experts in data science and this sort of field, and I can explain my situation to them. They can help me say, okay, these are the sorts of things that you may want to include in your system. A note about synthetic data here. I could just say, well, gee, I'm going to, if I make fake patients, then I don't have to worry about privacy. But if I'm making fake patients, I need to understand how to do that accurately. I can't just, for example, say I'm going to add 5 days to every patient's birth date, and then that's not a real patient, because it's too easy in those simple situations to then go back and reconstruct the real patients. Also, if you're contracting with companies and you want to make sure that if they're making synthetic data, say you have rules in your contract about what they can do with your real data, and then they say, well, I made synthetic data so that those are not covered by our contract for privacy. You want to make sure that you understand how they're building that synthetic data and potentially include in your contracts that they have to treat any synthetic data with the same privacy rules as your real data. It's fair to say that no data are anonymous. They're just more expensive to re-identify, and that's usually because they have quasi-identifiers, which these statistically rare attributes, which could be very small amounts of information in each individual data. And you can put these quasi-identifiers together from disparate areas to identify the patients. We need to remember that there are no technical standards right at the moment for how to de-identify medical images or how much de-identification is enough. And especially we want to think about, if you have gruesome or guarded or embarrassing images, how are you going to do something to especially have an extra level of security on those? If you're going to do those things, you need to think about them up front. Trying to do it retroactively is just impossible. This is something you need to remember. Any data that you release is going to get used in ways you don't anticipate. Let's just assume this, okay? So if you're releasing data up to a company or somehow it's getting outside your firewall, we've seen time and time again that the data are getting used in ways that we didn't think it just never occurred to us. So this should be our guiding mantra in terms of letting any data out, that it's going to get used in ways that we aren't thinking about. Let's switch and talk a little bit about data bias. I know this has been a big topic recently. There have been a number of papers about data bias coming out. Again, all data sets are biased. the things that happen for us in radiology are commonly confirmation bias, where we're using the data to reinforce preconceived notions, selection bias. We'll talk about that in a minute. Outliers, in particular, is a problem for us where you have extreme data values that are outside our normal distribution. And oftentimes the products that we're seeing today haven't thought of that. We'll get to that in a minute too. Overfitting or underfitting, our data will bias how useful those data are. And then confounding variables. Again, we can get bias from historical things, even if we sample perfectly, but the data when it was acquired was biased, that can be a problem. If we're over or undersampling subgroups, and specifically for us, again, a lot of what we do is supervised machine learning, which requires both the images and some sort of label or measurement. And when we're choosing or measuring these particular features, we need to remember that anything that we're doing that way is a proxy label. It's a label that's acting as a proxy for a real feature of the patient's true phenotype. So from those labels, we need to think about, okay, how consistent are our labels? How accurate are our labels? Or the labels, they're all going to be a little bit noisy because they're obtained from multiple annotators, and some of those annotators are unknown quality or expertise. Some are overcallers or undercallers. There's just going to be noise in the labels. Some of that is, in cases where it's just hard to make the decision, is something abnormal or not? And we want to make sure that if we're going to do the labels, that they are clinically relevant. We've seen people trying to build machine learning tools, and they've labeled things, and they're just not making their labels clinically relevant. The amount of information provided by different levels actually probably is really important. It might be, having a label of just, okay, is there an acute hemorrhage, yes or no, versus, what type of hemorrhage is it, where is it, how big is it? Labels with more information are potentially going to be more useful. For example, or maybe I shouldn't say more useful, more accurate. For example, if I'm doing bounding boxes, do I want to do rectangular bounding boxes, or do I want to do polygonal ones? Or how many labels do I want on an image? Do I want to label every abnormal image finding on an image, or am I just worried, am I just going to do one specific thing? Again, the hemorrhage, yes or no. Okay, and this is a fascinating paper, and I just came across, Rachel Drelos gave a talk the other day where I saw this, and she has this incredible data set of chest CT volume, and she trained it first on 9 labels, and then she looked at 83 different kinds of pathology. And this, I've got these 2 parts circled. I didn't know this before, and I don't know if any of you have, but when she trained it on the 9 labels, her AUC curves were lower than for each of the 9 labels than when she trained it using all 83 labels. Now, probably this is because if you've trained it on all 83, then it knows that some of the things that are maybe in some of those other 83 labels than are not in these 9 particular labels. But I think that's a fascinating thing and deserves more research for all of us. You know, these are the kinds of things that you see usually for bias. We think about these where typically what's happening is that we're not sampling all these kinds of groups, you know, and these are the sorts of things that you think about whether you're looking at radiology or any other type of decisions that are being made. There's some that are specific to radiology or important to us, I should say, and we'll look at some of those. The confounding attributes is an interesting one. You know, if this is a CT scan from one of the large studies that was done to evaluate TB. Now, if you have all these patients and they're even the ones that might have HIV, if they have adequate T4 counts, they're going to show these infiltrates in the upper zones. But if you take it then and decide you're going to apply it to a developing country where perhaps, you know, the radiographs aren't of the same technical quality and patients have very low T4 counts and are really severely immunosuppressed, they can have terrible TB and the X-ray is still potentially going to look normal, certainly in your AI program. Let's think about data. So pink cells, you know, in pathology are usually considered normal. Purple cells are cancer or bad. You know, so what I'm going to do is, you know, if I have humans labeling things as, say, cancer or not cancer, there's going to be a diversity of opinions. Some are low undercallers, some are overcallers, and if, you know, I might change how sensitive I am based on other information about the patient. When I have an AI algorithm, it's very rigid. It's going to pick a place. Now, it may be, quote, better than doctors, but it's just one place and it's not going to vary or be influenced. And I think we haven't studied, you know, what the effect of that is going to be overall on healthcare. Okay. The other thing is, so you know, suppose the AI trains to build its algorithm here, and then I put it in a different setting where all the cases are out here. Now, potentially the AI algorithm has never even seen these kinds of cases, and it's unclear oftentimes whether it's going to work or not. You know, we also as humans can see this. Certainly, like I went and I taught at a medical school in Africa, and all of the things that I had learned about subtle variations between, say, neuroblastoma and lymphoma in an abdominal CT scan made no difference when every scan that I was seeing that the entire abdomen was filled with tumor. I needed to learn a whole new way of trying to differentiate those diseases. Data sets shift. This is an unsolved difficulty and probably one of the biggest issues for radiology AI. So each imaging machine has its own pixel fingerprint. You know, first we're collecting, say, the sinusoidal data for this CT or MR. You know, the low frequency stuff is in the middle, the higher frequencies are around the outside. Then it gets reconstructed into the image that, you know, we're used to seeing. You know, both of these parts are different for each machine. It's a little bit like Finding Waldo, right? You know, Waldo's that character and it's always in a picture. So when we get the first Waldo, we might, if we want to identify him, we're going to find all sorts of features, right? How his hat, his hair, his glasses, sweater, color of his pants, his cane, all those different things. And if everything I'm training on all looks like him, I'm going to be just great at identifying Waldo. Probably find him, my machine's going to do better than doctors. So then I go and I give it to the next machine though, and all of a sudden maybe it's producing images a little bit differently. Now all of a sudden I can't use the glasses as a feature, and the hair's a little bit different, and I have to change the way I'm doing the features to say, instead of blue pants, maybe it's just blue lower garments and they might be a different hue. And then I go and I add other things, and I'm going to limit my features even more. Now I can't use potentially the skin color or whatever. What happens when we get this? Well, it's Waldo-ish, but is it Waldo? That's a difficult thing. And then you get this, well, this is Waldo-ish too, but we could almost certainly, definitely say this is not Waldo, okay? Then suppose we figured all this out and we're just doing great. We really got our system going, and then all of a sudden along comes some sort of data and disease that we've never seen before, okay? We aren't even going to recognize potentially, what's going on. We haven't figured out how to do all these different things yet. It's important to understand that the model knows the rules, but the physician may know the exceptions at the moment at least. Then you have adversarial images. This is the adversarial panda. You've probably all seen this. The initial picture, the AI figured out it was the panda. You add a little bit of noise. To us, it still looks like a panda, but it fools the AI. These are all kinds of areas where you're just changing the pixel patterns a little bit, changing the distribution shift. And one of the important things I think that we're going to have to do and start including in our machine learning models is how robust we are to distribution shift. Certainly we want to be able to predict it. Here's a good paper predicting uncertainty measurements of, how certain are we that these things, that our decision is the way it's supposed to be. That's a helpful thing. Now, if we go back to the panda, yeah, they're predicting it too, and they were wrong, but with 99% confidence. The algorithms being used to predict uncertainty are improving all the time. And again, this goes back to, we need to make sure that we have our appropriate communication with true technical experts to understand how, say, these complicated statistical models are changing and how we are going to adapt those into our use. How can we improve our robustness? Well, we certainly, if training on more disparate data and just more data, that's going to help, no question. But then there are other things, if oftentimes we augment data, and there's simple ways to do it. I can flip things, I can rotate them, but we need even more sophisticated technical approaches to data augmentation. Gaussian augmentation, where you're doing sort of a statistical variation of a lesion, or doing adversarial training, both of those work. It's interesting, there's a paper out that just came out about that these sorts of things improve robustness to the high frequency features, but it decreased the robustness to the low frequency features. This suggests that maybe that this is an approach to trying to figure out how to deal with adversarial images. Again, that's complicated statistical evaluation, and it's an area of research that hasn't been figured out yet, but we need to make sure that we have the appropriate communication with the experts who are doing this kind of research. There is something called Google's Auto Augment, and I'd suggest you look at it because what it does is it finds combinations of augmentation policies that will give the best results on your validation data set. So what it's really doing is telling you, okay, maybe, gee, if I flip and enlarge a little bit, then that sort of thing is helping me to be more accurate. It might improve my robustness, again, against data set shift. There's been a question about whether we could build deep generative models to vary data over a range of natural conditions. So in essence, what we're going to do is we could build models that would simulate, for example, that MR where I had the sinusoidal data. Could I build them which will change the data to mimic, for example, all of the different MR scanners from all the different vendors? And I could maybe learn those variations a priori, either I know them a priori or I can learn them, and that might help me. We need to include out of distribution detection and management. This is just super important. And that's what you're doing is you're trying to distinguish between data that's anomalous or significantly different from that used in training. Because right at the moment, almost all the algorithms that we have will classify out of distribution inputs into in distribution classes with a really high confidence. And here's an example. There was a bone age algorithm, one of the ones in the recent challenge. So we put Adam Flanders sent me this. He put a brain MR image in and it accurately predicted that the bone age is 9 years, 3 months. And it even gives me standard deviation and upper and lower limits, okay? This is wrong. And almost all of our current systems do this. And we need to, again, we need to make sure that we've added in procedures that are going to help us recognize when these things are going on. The easier way to say that is machines should include the category always, I don't know, ask a human. You also have the long tail of clinical diagnosis here. Suppose in this case, this right frontal cortical lesion in a young woman is usually an oligo or ganglioglioma or maybe an astrocytoma, but we want to remind everyone to consider a DNET, which is a much less aggressive lesion. And how are we going to build AI to incorporate these rare but important categories? Now that paper that Rachel had suggests that, potentially if we put all these other diagnoses in, that it'll make us more accurate even at detecting the common diagnoses. But it's an area, again, of research, but it's one that we're going to need to work on. So we talked about the verification side of the independent verification and validation, but let's go back to the validation. So now we finally build our tool and we want to ensure that the right tool's built. At the end of the development process, we want to make sure, again, that it satisfies technical, ethical, and contextual requirements. And we also want to specifically test where we expect the software to fail. For example, that bone age algorithm. We want to give it, some images that simply aren't appropriate. Give it an elbow X-ray or give it even a brain MR and see what happens. And we should always be doing this, the other thing we want to do is reproducibly be able to measure ethical AI in a clinical sense is it accurate and consistent? Is it robust to this data set shift in adversarial images? How do we manage the out of distribution images? Personally, I think this is going to require randomized clinical trials. Now, anybody who's in manufacturing is probably pulling their hair out when I say that, because now all of a sudden it's going to take this from a relatively easy approval process to incredibly expensive and long thing. But if we're going to have true, safe, ethical machine learning that patients are going to trust, I think we're just going to have it. And we also need to make sure that in these randomized clinical trials that we're including traditionally underserved groups. These clinical trials have to have short and long-term follow-up. We probably also want to have outside observers, which is the public and patients, just again, the smell test, because these things aren't going to be perfect, and it's like, what is everybody comfortable with? I want to end with this. Mark Coley and John Mongren recently wrote a paper about the 737 MAX, which I'd recommend you read. It's really a fun paper. Boeing has their own IV&V program, but it failed miserably on all three parts. Failed technically because the tube and the software that they had to manage the pitch didn't work correctly. They failed ethically because they lied about how much they tested it and how it was going to work. And they certainly failed contextually because their planes flew into the ground and people died. We don't want that to happen to radiology AI. And if we aren't careful now, those things are going to happen. And so I think, it's imperative to us to try to step back, take a big breath, realize this is going to slow down, making the algorithms like we showed on that technical debt slide, but at the end, we're all going to be more pleased and it'll be more successful. So thanks very much. I'm going to step out and quit sharing my screen here, and we'll take questions.
All right, thank you very much, Raym, for this fascinating presentation and lecture. And maybe it will be, I already mentioned it, by the way, in the chat box. It would be good for the attendees to look for the paper that we published, The Ethics of AI in Radiology, which is a summary of the joint European and North American multi-society statement. This paper is freely accessible online. It was published in 4 major journals. So actually, this paper addresses the most topics that you mentioned here. Until so far, I don't have any questions in the chat box, but I do have some. So yes, of course, you can expect this from me. But okay, of course, the bias issue is very important, and we should avoid this in any way. And one of the issues that is causing the bias is, of course, the lack of data, which is an essential issue for the developers of AI tools. So the more data we have, the less bias we can, or the more we can avoid bias. So how can we enhance the availability of data? Don't you think that at this moment there's too many ethical and legal questions or issues that are hampering this process? What do you think about that?
Well, I'm a little bit biased. My disclosures are, working for the ACR's Data Science Institute. We're building something called AI Lab, which is for federated learning. There are probably 3 different ways that you can get data. One, you can release data from your own institution, or sending your data to the algorithms, we call it. The other way is to flip that and bring the algorithms inside your own firewall. So bringing the algorithms to the data. and their process is called federated learning, and that's what the AI lab is hoping to do. Now, I will say that even if you're doing it that way, you probably need to, if you're being really rigorous, you probably need to do things to camouflage the data with statistical methods or securing different parts of the data inside your own firewall, because those quasi-identifiers are still visible outside. But that would be one way, and I think that that's probably the way that this, at least in the United States, I think you're just seeing more and more hospitals, they started sharing their data and then they've gotten burned repeatedly. So the most sophisticated places, at least, are really, they're not letting their data out.
Mm-hmm.
Well, I shouldn't say all of them. There is a difference of opinion. So say in the United States, the famous places, Stanford keeps releasing these open data sets. I disagree with that in terms of the privacy and these things we've just talked about. You can certainly HIPAA or GDPR, I assume, are not adequate. HIPAA rules were set up before Google or Facebook even existed. Nobody anticipated the way that people might collect data. And HIPAA doesn't specifically talk about images. So things that are like quasi-identifiers on images would be, the easy ones are things like a pacemaker that might have the ID number on it. But, each one of us, just like you have facial recognition, my liver looks different than yours. Mm-hmm. You could reconstruct pictures of my face. Those data aren't anonymous. Those images are unique to you. So I'm just not a big fan on releasing data. Mm-hmm. Right?
But on the other hand, we can feel also, for example, from my experiences, that I'm also active in the international initiative where imaging for making an algorithm to analyze COVID-19 abnormalities in the lungs.
Right.
There's still a lot of issues to be solved before you can obtain any data from the hospital. So this is kind of slowing down the process, whereas we are in the middle of a crisis, so we need to develop something accurate within a short time. So this is here you can ask yourself, what's the importance or the relevance of the privacy, the individual privacy versus the common benefit? So those are also questions we should ask ourselves. This is finding a balance between the value of the privacy and the common value,
Yeah, and that goes back to the slide I had. What compromises are you willing to make? Mm-hmm.
And then
I
also
think,
for
in something like this, the COVID, potentially you make, you try to keep the data as private as possible, but understand that the data won't be private.
Yeah.
So, but you're doing something to, try to save mankind right at the moment, sort of.
That's it. There's a question from Paul Algra. He's saying, when using AI and in case of misdiagnosis, who is to be held responsible? Is it the AI supplier? Is it the one who labeled the training data set? Is it the radiologist using the AI? So, and are you aware of cases where AI was wrong? And do you know any, let's say, discussions that took place in this field? Any legal issues?
Well, I'm definitely aware of cases where the AI was wrong. And I think any of us who have those cases that are reordering our work list because they're trying to identify acute hemorrhage. You know, cases get put on the list that don't have hemorrhage. They've got streak artifact or
False
calcification or
positives.
whatever, or just artifact from the scanners. But we've also seen it the other direction where the algorithms have just plain old missed the hemorrhage. You know, not big ones, but clinically significant ones. To my knowledge, none of those have been resulted in litigation yet that I know of, but it's only a matter of time.
Yeah.
And certainly, at least in the United States, when you read these contracts from the AI companies, they're like, "Oh no, we're just helping you. You know, we're not really making the decision." I mean, they may have their PR stuff saying, "Oh, we're better than doctors, and you know, we're going to replace the doctors." That's certainly the pitch that they're using to their investors.
Yeah, right.
But they're turning around and saying, "Oh no, we don't do that."
Yeah, I agree with that.
Yeah.
So there, we should look at AI as assistants. It's not replacing us at this moment. I have another question, Raym. So what was interesting in your lecture is the topic about the independent verification and validation. So my question is, who should actually score the algorithms? Is that an independent, what kind of independent organ do we need? For example, could this be a role for a society like the ESR or the ACR? And so actually, what do they need to do this? Don't we need some kind of a reference validation data set to test algorithms? How should this be organized? Do you have any idea?
Well, I can tell you at the American College of Radiology, we're just talking about this exact question. I mean, they're not, they haven't said, "Oh yeah, we're going to do it." Initially, like 4 or 5 years ago when AI first happened and we were talking at the ACR, we proactively decided that we were not going to be that validation group. And the reason we weren't going to do it was because many factors, but the biggest factor was just the technical issues around trying to collect appropriate data sets. And going back to that, my slide, if you're really going to do this correctly, it's not just saying, "Oh, I've got a bunch of cases of, say, intracranial hemorrhage, yes or no, and I'm going to just see if that works." I mean, that's kind of like saying, "Oh, can my self-driving car drive down a straight highway, without, with everything just the way it's supposed to be?" We've got to think, again, we've got to go back to the experts who deal in biostatistics and data science and say, okay, which are the cases that we assume the algorithm isn't going to get right? And then we want to make sure we've included that kind of case in our test set so that we can look and see how the algorithm deals with those.
So some kind of tricky cases.
Right. And, out of distribution cases is the easy one.
Mm-hmm.
Throw a CT.
That was a nice
I don't know
example.
how many of you have done this, but you take a picture of your own dog or cat and feed it into any one of these algorithms, and it will give you the answer based on whatever it is, hemorrhage or no hemorrhage or whatever. It's just scary, and it happens almost, just with such frequency.
Yes.
So we have to come up with all of those things. It's a very complicated deal to test these from a technical standpoint.
And we will need
you have the companies like, you have the the FDA in the United States. They're, right at the moment, in my personal view, they're just failing miserably. they're not approving them, they're clearing them. And clearing is based on just saying, well, it's kind of like some other algorithm. And so we've had FDA approval for tests where they have only tested on 5 cases. I'm not making this up. I mean, it's a failure right at the moment.
But nevertheless, the FDA approval is being used as a valid reference even in Europe. I mean, when we see the AI vendors selling the products, they always refer to the FDA approval if they have it.
Right. And you should correct them if they say the word approval, because none of them have approval. They all have clearance, which means, well, we're sort of like, almost all of them are using breast CAD from 20 years ago and saying, well, ours is just like breast CAD, so no big deal. Yeah.
I have another question, Raym, that's more related to the education of radiologists. So what basic knowledge do you think radiologists should have about AI, including the ethical and legal issues? How should they obtain it? Should it become part of the medical training or the training of radiology residents? And maybe this is coming close to the organization of the NII course, imaging informatics course, as you have been you've been setting up this course with SIM and the RSNA. So do you think this is the ideal way and to train radiologists, or what else do you think we need?
This is so hard because, as you know, I mean, there's so much to learn in radiology already. I think that it's sort of like radiologists learn medical physics right at the moment. I think we need to learn enough that we can communicate at baseline, all of us need to learn enough that we can communicate intelligently with people who are true experts. I think, again, this is my own personal viewpoint. I think that the way this is all going to end up working in terms of, when you're doing this stuff at scale and you don't have just one algorithm in your place, but you've got 100 algorithms, and they're all in what are called dynamical network systems, so they're feeding information to each other, that all of this is going to be dealt with much like we do with medical physics for radiation therapy at the moment. You have a medical physicist, they come in every morning and do some checks on the system, and then once a week, say, they'll run an entire simulation beginning to end to see how well everything's working. I don't see how we could do this otherwise, but I don't think that right at the moment, I'm not sure what skills that person's going to have. Is that person going to have to go all the way through a radiology residency and then
maybe
get a PhD too? I would guess not.
But personally, I see this as an opportunity to reorganize the radiology department. When we started with PACS systems, we also included or engaged a PACS manager in the department to manage the PACS system and the digital infrastructure. Maybe we should also find a new partnership with other experts like clinical physicists or data scientists to run this part of our infrastructure in the radiology department. Maybe we are now at a moment where we should revise the way we manage the whole department. And personally, I also think that at least there should be basic knowledge among radiologists of AI, as we learn similar to what we learn about MRI, physical principles. So we know what kind of images MRI can produce and what kind of artifacts it can produce. So the same thing is, I think it's similar to what we will encounter when we use AI. There will be artifacts or errors that can be made, and we should be aware of that and why it can happen. Don't you share that opinion?
Yes. I mean, I agree with what you just said. I would say a couple of things. So if we go back to PACS, when it first started, you know, it was all of us as radiologists were really super involved in everything. I mean, heck, you know, I mean, I helped string Cat5 cable through the ceiling. But then it shifted. They, you know, the hospital said, okay, now it's in, it runs just fine. I want you as a radiologist to go back to reading CT scans, and we'll hire PACS administrators to do that. And the radiologists separated from those places. Now, I happened to work for a while in two different big private hospital systems. One where, you know, frankly, I was the guy in charge of the PACS, if you will. I mean, I had a team of people and technically were underneath, but when we were trying to figure it all out, how to make it run, you had a radiologist super involved in it. On the other hospital, it was like they said, no, you can't even, you'd have nothing to do with it. We're going to tell you how it goes. We actually did studies there and found out that the one that, you know, where I was heavily involved, all the radiologists were 15% more efficient than one not. Now, you know, you can do the math there. You know, you got 100 radiologists in your system. And they told me, well, gee, you know, it's not worth your time to go help. But, you know, I'm saving 15 radiologist salaries in the other hospital. So we want to make sure that radiologists remain deeply, deeply involved in these things. Right. And it's even more important here where you have these intelligent and autonomous systems that are going to be making clinical decisions.
Making clinical decisions. That's the thing. Yeah. Okay, so we're running out of time, unfortunately. So Raym, I would like to thank you again for this very interesting talk and this nice discussion afterwards. And I would like to continue, but I'm afraid we we have to stop here. I would like to tell everybody, all the participants, I would like to thank them first for having attended this meeting and this webinar. And this meeting is being recorded, so it will be available on the website of USOMI. If you want to look at it afterwards, please go ahead. And also you can share this presentation, of course. So thanks again to Raym for this lecture. We would also like to thank our sponsor, Bracco, for supporting us in setting up this webinar program. And of course, we have these webinars every month. So we would like to invite you to attend the next one as well. So thank you again and have a nice evening, everybody.
Thanks. Bye.
Bye-bye.